Hello everyone. In the previous video, we have studied the coagulation pathways. There were two coagulation pathways. One was extrinsic and the other one was intrinsic. Now we're going to study their disorders. So basically in this video, I am going to explain hemorrhagic disorders. The hemorrhagic disorders can be of two types. They can be primary hemostatic disorders as well as secondary hemostatic disorders. Now we will first of all study that what these terms are meant to. Primary hemostatic disorder means the disorders that are associated with the primary hemostatic plug formation. So if you guys can recall the previous lecture, I have mentioned that platelets are involved in primary hemostatic plug formation. So whenever there is any abnormality with the platelet count or platelets shape, structure and anything, means that whenever there are effective platelets or there are low platelet count, there will be the primary hemostatic disorder. Now, the first reason for the primary hemostatic disorder is low platelet count. How many conditions there are in which there is low platelet count? The one is basically the platelets are formed from the megakaryocytes in the bone marrow. So whenever there is any abnormality in our bone marrow, there will be low platelet count. Because the platelets are formed from the megakaryocytes present in our bone marrow, so whenever there is bone marrow abnormality, there will be the low platelets count, or maybe there is disseminated intravascular coagulation. When there is disseminated intravascular coagulation, there is consumption use. There is a lot of consumption of platelets, which can lead to the low platelet count in our circuit. So whenever these two conditions are present, the low platelet count, there are various other conditions in which there is low platelet count, and they will lead to the primary hemostatic disorders. The second thing in primary hemostatic disorder is defective platelets. Now, platelets are defective in how many cases? There are a number of cases in which platelets become defective. For example, first one is uremia. What is uremia? It is the buildup of toxins due to kidney failure. Like kidneys, there is end kidney failure and the kidneys are not washing out our toxins. So there is accumulation of toxins in our body. So these toxins, these uremic toxins will make our platelets defective. The second reason can be antiplatelet drugs like aspirin. If we are using antiplatelet drugs, then there will be the defective platelets, which can lead to the primary hemostatic disorders. Now, we have studied the basic reasons of primary hemostatic disorder because the platelets were involved in primary hemostatic plug formation. So whenever there is any abnormality associated with the platelet count or their structure, there will be the primary hemostatic disorders, and that will lead to the superficial bleeds, like bleeds of your vasculature of mucosa or skin, which can lead to the nosebleed like epistaxis, the GIT bleed, excessive bleeding during menstruation, that is menorrhagia, and ecchymosis. Now we will study the secondary hemostatic disorders. Now we first have to go through that which structures were involved in secondary hemostatic plug formation. So there were coagulation factors, there were clotting factors, from 1 to up to 13 they were involved in secondary hemostatic plug, which leads to the formation of fibrin, which is an insoluble meshwork that surrounds our platelets to form the secondary hemostatic plug. So secondary hemostatic disorders are associated with any abnormality associated with our clotting factors. Maybe there are less clotting factors in our bloodstream, like there is some liver problem, because the clotting factors are formed inside our liver. So whenever we are having some liver disease, there can be low clotting factor count. So first thing is low clotting factor count. Low clotting factor count can be due to liver disease, because clotting factors are made inside our liver. And then there can be vitamin K deficiency, because vitamin K is necessary to for activation of these clotting factors. Vitamin K causes the carboxylation of gamma glutamic acid, which can lead to the activation of these factors. So vitamin K deficiency can also lead to the low clotting factor count in our bloodstream. The third reason can be warfarin use. If we are using warfarin inhibits this vitamin K activation of clotting factors. So that is how warfarin use causes low clotting factors in our bloodstream. And the fourth thing can be heparin overdose. If you guys go through my previous lecture, then I have mentioned that on our endothelium there is present a gag which is known as heparin sulfate. Then heparin sulfate binds to the antithrombin 3, and which can lead to the inactivation of factor 9-10. So this is how heparin overdose causes low clotting factors. Now the second thing is clotting factors, presence of clotting factor inhibitors. If there are present clotting factor inhibitors in our bloodstream, we are taking some drugs, then there will be no clotting, no secondary platelet plug formation. Now both of these things leads to the deep bleeds. In primary hemostatic disorder, we have studied that there are superficial disorders like epistaxis, GIT bleed, etc. But in the secondary hemostatic disorders, there are deep bleedings. For example, bleeding into soft tissue, which is known as hematoma, and bleeding into our joints, which is known as hemorrhasis. So secondary hemostatic disorders will basically lead to the deep bleeds like hematoma and hemorrhasis. These are the hemorrhagic disorders. Now switch back to the primary hemostatic disorder. Let's have a diagrammatical view. Consider this is our endothelium. Now we know we have a layer of endothelial cell. And then we are having a subendothelial layer in which our connective tissue, collagen, etc. is present. And the third layer is of smooth muscle cell. Now, whenever there is some injury on the endothelium, subendothelial layer become exposed, and here on collagen there is present a factor which is known as von Willebrand factor. Consider this is collagen, and here is von Willebrand factor present. Now the blood is flowing. The blood is flowing through our vessel. Certainly the platelets come into contact with these von Willebrand factors. Now what happens? Consider this is a platelet. Platelet has a ligand which can bind to this von Willebrand factor. Platelets is having a glycoprotein 1b ligand which can bind to this von Willebrand factor. So basically this von Willebrand factor is acting as a bridge between our collagen molecule and then a platelet. So whenever this platelet will come into contact with this von Willebrand factor, it will rush toward it and binds with the help of glycoproteins 1b to the collagen molecule. Now basically there are two things in primary hemostatic plug formation. There is first one, the platelet adhesion through glycoprotein 1b, and then there